Let me tell you a story about a patient. Let's call him Arthur. Arthur was 78 years old. He was vital. He played golf twice a week. He drove his own car. He felt perfectly fine. But Arthur was a responsible man. He believed in doing the right thing for his health. So, even though he had no symptoms, he went to his doctor for a comprehensive annual checkup. The doctor ordered a battery of screening tests, just to be safe, just to make sure. One of the scans showed a tiny, ambiguous shadow on his kidney. It was probably a cyst. It was probably nothing. But the protocol says we must investigate. So Arthur was sent for a biopsy. It was a minor procedure, routine. But during the biopsy, the needle nicked a small blood vessel. Arthur had internal bleeding. He had to be admitted to the hospital for observation. While in the hospital bed, immobile, Arthur developed a urinary tract infection from the catheter. The bacteria were resistant to standard antibiotics. The infection spread to his blood. It became sepsis. Arthur survived the sepsis, but the antibiotics damaged his hearing and weakened his kidneys. He lost 20 pounds of muscle mass lying in that bed. When he finally went home, he could no longer play golf. He was frail. He was depressed. He spent the last 2 years of his life in a chair. And here is the tragic punchline. That shadow on his kidney, it turned out to be a benign cyst. It would never have harmed him. Arthur did not die from cancer. He did not die from kidney disease. Arthur died from the checkup. This is not an isolated incident. This is a phenomenon that has a medical name. It is called the Cascade of Intervention. And if you are over the age of 70, this cascade is the single greatest threat to your longevity. We have been brainwashed. For 50 years, public health campaigns have told us early detection saves lives. Prevention is better than cure. Find it early, fix it early. When you were 40 or 50, this is absolutely true. But today, as a senior doctor, I'm going to tell you a controversial truth, a truth that many of my colleagues are afraid to say out loud because of lawsuits or hospital quotas. When you cross the threshold of 75, the rules of medicine flip upside down. Aggressive screening for diseases you do not feel often causes more harm than the disease itself. We are going to explore the concept of iatrogenesis. This comes from the Greek iatros, meaning doctor, and genesis, meaning origin. It literally means doctor-caused harm. Studies show that medical error and iatrogenic complications are the third leading cause of death in the Western world. Why is this happening specifically to seniors? It is not because doctors are evil. It is because we are applying a young body protocol to an old body reality. We need to talk about your biology. We need to talk about homeostatic reserve. Imagine your body is a car. When it is new, it has shock absorbers. If you hit a pothole, the car bounces and keeps going. That is reserve. You can handle stress. You can handle a surgery. You can handle a harsh laxative preparation. But as you age, you lose that reserve. This is not a failure. It is nature. Your shock absorbers wear out. Your kidneys filter blood more slowly. Your blood vessels are stiffer. Your intestines are thinner. This condition is called frailty. Frailty means that a minor stressor like a colonoscopy preparation or a needle biopsy or a contrast dye injection can cause a system crash. The pothole that a 40-year-old drives over without noticing can shatter the axle of an 80-year-old. So, when we go looking for problems in a senior body, we are playing a dangerous game. We are poking a fragile system. We are looking for incidentolomas. An incidentoloma is a lump, bump, or shadow that we find by accident. It wasn't hurting you.
You didn't know it was there, and statistically, it was probably going to sit there quietly for the rest of your life. But once we see it, we feel compelled to attack it. We biopsy, we operate, we radiate. And in that process, we take a healthy,
Let's begin with the most invasive routine procedure that millions of seniors submit to every year, the colonoscopy. For decades, we have been told that this is the only way to prevent colon cancer. And for a 50-year-old, that is true. It is a lifesaver. But if you are 75, 80, or older, and you have no symptoms, meaning no blood in your stool and no unexplained weight loss, a routine colonoscopy is statistically more likely to hurt you than to save you. Even the United States Preventive Services Task Force, the governing body that sets the rules for doctors, recommends stopping routine screening at age 75. Why? Why is there an age limit on safety? It comes down to the structural integrity of your organs. We need to visualize the geriatric colon. As you age, the muscular walls of your large intestine weaken. Under the pressure of decades of digestion, small pockets or bubbles form in the lining. This is called diverticulosis. By the age of 80, almost everyone has these pockets. Think of your colon like an old bicycle tire. The rubber is thin. It has weak spots. Now imagine inserting a rigid camera tube into that old tire and inflating it with air to look around. In a young, elastic colon, the tissue stretches. In a stiff, diverticular colon, the tissue tears. This is called perforation. It happens. The camera punches through the wall of the intestine. When this happens, bacteria from the bowel spill into the sterile abdominal cavity. This causes peritonitis. It requires emergency open surgery to fix. It involves a colostomy bag. And for an 80-year-old, the mortality rate of this complication is terrifying. But the danger starts even before you get to the hospital. It starts in your bathroom the night before. To get a clear picture, doctors prescribe a bowel prep. This involves drinking gallons of a powerful industrial-strength laxative solution. The goal is to flush out everything. But it does not just flush out waste. It flushes out water. It flushes out electrolytes like potassium and sodium. For a senior body with reduced kidney function, this rapid dehydration is a shock to the system. It can cause acute kidney failure. But even more dangerous, the drop in potassium can trigger the heart. It can cause an arrhythmia, an irregular heartbeat that can lead to a stroke or a cardiac event right there on your bathroom floor. I have seen patients survive the cancer they might have had, only to suffer a stroke from the preparation to find it. So, we have established the risk, but what about the benefit? Aren't we finding cancer? This brings us to the most important mathematical concept in geriatric medicine. It is called lag time to benefit. Colorectal cancer is generally a slow-growing disease. It starts as a small polyp. It takes 10 to 15 years for that polyp to mutate into a dangerous cancer that threatens your life. If you screen a 50-year-old and remove a polyp, you're saving them from dying at 65. That's a win. But if you screen an 80-year-old, you are preventing a cancer that would not become fatal until they are 95. We have to have a hard conversation about competing causes of mortality. If you are 80 years old, statistics say that heart disease, stroke, or respiratory issues are much more likely to affect you in the next 5 years.
Now, let's address the men in the audience, specifically the men over 75. There is a simple blood test called the PSA, prostate-specific antigen. For years, it has been part of every routine checkup. But did you know that the man who discovered the PSA, Dr. Richard Ablin, later called the mass use of this test a public health disaster? Why would he say that? Because the test is not a cancer detector. It is just a prostate activity detector. The PSA measures a protein produced by the prostate cells. Yes, cancer makes it go up, but do you know what else makes it go up? A benign enlarged prostate, which almost all older men have, an infection, or even just riding a bicycle before the blood draw. So, you get a high number, you panic, the doctor panics. This triggers the cascade. You are sent for a biopsy. A prostate biopsy involves shooting a spring-loaded needle through the rectum and into the prostate gland 12 times. Remember our discussion about bacteria. The rectum is full of them. Shooting a needle through a dirty area into a sterile gland carries a significant risk of sepsis. About 2 to 4% of men end up hospitalized just from the biopsy. But let's assume you do the biopsy and they find cancer cells. This sounds terrifying. I have cancer. But here's the secret that oncologists know but often fail to explain clearly to patients. Not all cancers are killers. In the world of prostate cancer, we divide tumors into two animals, the rabbit and the turtle. The rabbit is fast, it spreads, it kills. This needs to be caught early, but the vast majority of prostate cancers found in men over 75 are turtles. They are microscopic. They are incredibly slow growing. Autopsy studies have shown that if you examine men who died of old age at 90, nearly half of them had prostate cancer, but they didn't know it, and it didn't kill them. They died with it, not of it. These represent indolent disease. But here's the tragedy. Once we find the turtle, the medical system is designed to kill it. It is very hard for a doctor to say, let's just watch it. And it is very hard for a patient to sleep at night knowing it is there. So we treat. We perform a radical prostatectomy to remove the gland, or we blast it with radiation. And this is where the iatrogenesis hits hard. The prostate is located in a very delicate neighborhood. It sits right next to the nerves that control erections and right next to the sphincter that controls your bladder. Surgery and radiation often damage these nerves. The statistics are heartbreaking. A huge percentage of men who undergo treatment for low-risk prostate cancer end up with permanent side effects. We are talking about urinary incontinence, wearing diapers for the rest of your life. We are talking about complete erectile dysfunction. Now, ask yourself the value question. If you have a turtle cancer that was going to take 20 years to cause symptoms, but you only have 10 years of life expectancy left, was it worth it? Was it worth trading your dignity, your ability to control your bladder?
We have looked at the gut. We have looked at the prostate. Now, we must look at the engine itself, the heart. It is very common for a senior to visit a cardiologist and say, "Doc, I feel fine, but I just want to check the ticker. Let's do a stress test." Or perhaps you are scheduled for a minor knee surgery, and the surgeon asks for cardiac clearance. So, you get on the treadmill, or they inject you with a radioactive tracer to take pictures of your blood flow. And very often, the test comes back abnormal. This triggers immediate panic. You think you are a walking time bomb. You think your arteries are blocked and you are about to drop dead. But here is the reality of the geriatric heart. If we take 100 healthy 80-year-olds, people who run, swim, and have zero chest pain, and we scan their hearts, a huge percentage of them will show blockages. It is like looking at the pipes of an old house. There is rust, there is sediment,
but the water is still flowing. The house is functioning. This is called stable coronary artery disease. The body has adapted to it. It has built natural bypasses called collaterals. But the stress test sees a shadow, and the cascade of intervention begins again. Because the stress test was positive, the doctor cannot ignore it. They order an angiogram, aka a cardiac catheterization. This is not a simple X-ray. It involves threading a long tube through an artery in your wrist or your groin, all the way up into your heart. Then they inject a heavy dye. For a frail senior, this procedure carries real risks. First, the dye is toxic to the kidneys. We call it contrast-induced nephropathy. If your kidneys are already borderline, this dye can push them over the edge into failure. Second, as the catheter travels through your old, stiff arteries, it can scrape off a piece of plaque. That debris travels up to the brain. It is a cruel irony. The test to prevent a heart attack can cause a stroke right on the table. But let's say the catheter gets there safely. The doctor sees a blockage. Aha, he says, we found a 70% blockage. We need to put in a stent. A stent is a metal mesh tube to prop the artery open. It sounds logical. The pipe is clogged. We open the pipe. Problem solved. But massive medical studies, like the famous Courage trial and the ischemia trial, have proven that this logic is flawed. For patients with stable disease, meaning you had no chest pain before the test, putting in a stent does not prevent future heart attacks, and it does not make you live longer. Why? Because heart attacks are rarely caused by the big, old, hard calcified blockages that we stent. Heart attacks are caused by the small, soft, inflamed plaques that rupture suddenly, and stents do not fix those. So, you get the stent. Now you have a metal object in your heart. To keep that metal from clotting, you must take powerful blood thinners, Plavix, aspirin. Now you are an 80-year-old on blood thinners. What happens if you trip on a rug? What happens if you bump your head? A minor fall becomes a life-threatening brain bleed. Do you see the trap? You went in feeling fine.
We have covered the dark side of modern screening, but I want to be very clear. I am not telling you to never see a doctor again. I am not telling you to ignore your symptoms. If you see blood in the toilet, go to the doctor. If you feel a lump, go to the doctor. If you have chest pain, go to the doctor. That is sick care, and modern medicine is miraculous at sick care. But I am telling you to be very suspicious of well care. I am telling you to be skeptical when someone wants to look for problems you do not feel. So, how do you handle this? You are sitting in the office. The doctor is busy. He has his checklist. He says, "Okay, Arthur, it is time for your colonoscopy and your PSA." How do you refuse without being rude? How do you protect yourself? I want to give you a script, a power question that changes the dynamic of the appointment. When a doctor suggests a test, look them in the eye and ask this: "Doctor, let's play a hypothetical game. If this test comes back positive, would you recommend aggressive surgery or chemotherapy for me, considering my age and my current frailty?" If the answer is, no, you are too old for that kind of surgery, then the follow-up question is obvious. Then why are we doing the test? If the treatment is too dangerous, the diagnosis is irrelevant. Do not let curiosity drive your medical care. Curiosity killed the cat, and it bankrupted the patient. Here are the 3 golden questions you must ask before agreeing to any new test after age 75.
Question 1. The time horizon. Will the benefit of this test happen in 1 year or in 10 years? If the benefit takes 10 years to show up and you are 85, the math does not work. Choose the present over the future. Question 2. The chain reaction. If this test is abnormal, what is the next step? Is it a biopsy? Is it surgery? Always look 3 steps ahead. Do not just agree to the blood test without knowing where the road leads. Question 3. The do-nothing option. What happens if we simply monitor my symptoms? This is called watchful waiting or active surveillance. It is a legitimate, scientifically backed medical strategy. Often, doing nothing is the hardest but the smartest thing to do. Aging is not a disease to be cured. It is a stage of life to be managed. The goal of medicine in your later years should not be to reach the age of 100 with a perfect set of lab numbers. The goal should be to maximize your health span, to keep you independent, to keep you out of the hospital, to keep you playing golf, gardening, and enjoying your family. Every time you enter a hospital, you roll the dice. You risk infection, you risk error, you risk immobility. The safest place for a healthy senior is not in a doctor's office. It is out in the world.